in our last class, what we discussed about what is electrocardiography. It is the method of recording electrical activity of the heart and presenting the record in the graphical form. Okay, so this is the electrocardiography, the method, and electrocardiograph is the machine, and electrocardiogram is the record, graphical record. Okay, that is electrocardiogram. Why we do electrocardiography? What is the significance of this method? Why we perform electrocardiography? Definitely it will give some information. What information it provides? These are the information it provides. What are these information? It gives about the rate, heartbeat, heart rate. What is the heart rate? And whether this heart rate is rhythmic, it is happening after a fixed interval. Okay, so with that we can determine whether it is heart rate is rhythmic. Then we want to know, for heartbeat we need to develop a cardiac impulse in the SA node. So because of this impulse our heart beats. We also know this impulse can also come from AV node. Also may come from bundle of his, may come from atrial muscle, may come from ventricular muscle, but this is normally not seen. Normally what we say, these impulses are formed in SA node and these are transmitted. Okay, so from here we want to know whether this cardiac impulse is originated in SA node or not, or it is in AV node. So if it is originated from SA node, we call it sinus rhythm. We call it sinus rhythm. So it gives about us about rate and rhythm of the heart. Okay, next is the physical orientation of the heart, that is the axis. Our heart may be oriented like this. It may be oriented like this. It may be oriented like this, horizontally. When it happens, when ventricle becomes enlarged, hypertrophied. So because of this hypertrophy, there may be axis deviation. So we can determine the axis also. When we find some changes in the wave that reflects the heart is hypertrophied, then we are interested to know what is the axis of the heart. So what is the orientation of the heart? So that information is also important for us. Physical orientation of the heart. Next, it is diagnostic. It can identify various diseases. Particularly, the heart is having wearing, as I said earlier. What wearing? What type of wearing? What is this wearing? Special junctional tissues through which cardiac impulse is transmitted throughout the heart, to the ventricle, to the septum, to all over the ventricles. So these are conducted by some path, isn't it? It's like AV node, bundle of his, right bundle branch broad, right bundle branch, left bundle branch. This sort of different pathways there. Whether any blockage is there, blockage means this discontinuity, like this wear may have discontinuity. Okay, if the fan is moving, if there is discontinuation, will the fan move? No. Similarly, if one of the tract or say left bundle branch, if it is blocked, then what will happen? It is supplying certain area. So that area may not get electrical impulse. However, it will get this from other sources. But normally it should get this, but it is not getting because of this blockage. And this will be reflected in your ECG. And with that reflection, you can identify, yes, there is right bundle branch block. How you can determine right bundle, for example? So what are the different waves in ECG? What are these waves? P, Q, R, S, T. We'll see this. So this R wave, no? Since R wave, R, P, Q, R, S. These three waves, for these three, normally there is some time duration, 0.08 to 0.1 second. If it is more than this, and the shape of this R wave is what? It is biphasic. Means RR pattern, SS, I will explain. RR pattern, SS pattern. This is R wave. This is R wave. If it is like this, notch, then we call it RR pattern. Since this notch appears first, so we'll write small r, and it is smaller than this, then we'll first write small r, then bigger, RR pattern. So in QRS, in R wave, there will be notching, and there will be widening of the time. QRS will take more time, means duration will be increased more than normal. So this is one. There are other changes. So this is one by which we can determine right bundle branch block. In that way, you can also determine, say, AV block. AV block means, or SA node, AV node dissociation. Means SA nodal impulse is not coming to the AV node. This is called, how you can determine? This is called AV block. SA nodal impulse is not coming to AV node. So it's called AV nodal block, AV block. So AV block can be of three types. One is first degree, another is second degree, another third degree block. What happens in first degree block? PR segment will gradually increase. So in one bit it was this much, in second bit PR interval with this much, third bit this much, then only again it will be small. So this sort of change, gradual increase in PR interval, it is termed as, it is known as, there is first degree AV block. Okay, second degree AV block means P wave should be always followed by QRS wave. So you in ECG you found one P wave DS, but it is not followed by QRS wave. It is followed by another P wave, again another P wave, then only one QRS wave. So what is this? P wave 2, then only one QRS wave. So the 2:1 AV block. In this way, there can be 3:1 AV block. So by this, there are different ways by which we can diagnose various disorders of the conducting system. Okay, so ECG is very important diagnostic tool for assessing this. Another thing is very important. What is this? Hypertrophies. Hypertrophy means thickening of wall of the atria or thickening of wall of the ventricle. If there is thickening of wall of atria, we call atrial hypertrophy, atrial enlargement. If there is enlargement is in ventricle, we call it ventricular hypertrophy. LVS, it may be in left ventricle, we call it left ventricular hypertrophy, in short LVS. So in LVS, one typical changes you will get in ECG. I'll explain what are how you diagnose. I'll give you some tracing. Can you tell me what is your diagnosis? So you know what happens in LVS and why it happens. You also know that. So you're seeing this, you can be easily identifying that yes, there is LVS. Okay. And ischemia, infarction. arrhythmia. In ischemia, the ECG can detect, as I said, on the conduction defect. Another defect it can identify, diagnose, if there is any problem in the myocardium. Myocardium is continuously working. And for this work, they need what? Oxygen supply. They need always, oxygen supply should be there. And because if in any case oxygen supply is reduced, how? By narrowing, because of narrowing of the coronary blood vessels. Coronary circulation, there are different blood vessels, left coronary artery, right coronary, these are having lot of branches. If one of such branches, for example, this part of the wall of the ventricle is supplied by a particular vessel. Now what is happened? This vessel became narrowed. Why? Because of atherosclerosis or arteriosclerosis. Same thing, atherosclerosis. So, because of atherosclerosis, the vessel became narrowed. As a result, what will happen? Less blood, less oxygen will be supplied to this. What happens? If I block your femoral artery by tying with a band, what will be your experience? What you will feel in your lower limb, right limb? What you will feel? If I occlude an artery, tingling sensation. Or there is, you won't get, after some time you won't get any, as if no sensitivity is there. Okay, and also pain. And this pain is called angina pain. This pain is called, why? When there is short supply of oxygen, then any tissue will give you a signal, pain signal. So our heart is also, when it suffers oxygen supply, then lack of oxygen supply, then it will also produce a symptoms. What is this symptom? There will be pain. This is called angina pain. So when a patient comes to you and you will say, I am feeling heaviness. When I walk a little bit faster, then I feel pain. And when I take rest, it goes away. So when I walk with my friends, I cannot keep pace with them. I always remain behind. So these are some indications. These are some indications that he might be having coronary arterial disease. So what you will be doing? Immediately, okay, go for a ECG. If there is any change, really there is change, it will be reflected in your ECG. Okay, particularly in ST segment and in T wave. So by noting these changes, you can say, yes, there is ischemia. Or if some portion is damaged because of some, now no short supply, blocked. Now this area will not get, means this area will be becoming infarcted. So when there is infarction, again this part, means ST segment and T waves, they will reflect these changes. And you can confirm that yes, he has suffered heart attack. Okay, so that's why it is very important for you, isn't it? So you have to, sometimes you are given duties in emergency. So emergency patient, you have to perform ECG. So by looking at this, initially you have to take the decision. Okay, so then you have to take the management. Either you will be calling your seniors or you have to take the decision immediately. Okay, so this is important. So in that, by studying ECG, you can also identify infarction. Arrhythmia, no rhythm. See, when you inhale, you are young, and your breathing, with your breathing, your heart rate also changes. When you will be inhaling, your heart rate will be increased. As a result, cardiac cycle will be shortened. As a result, PR segment will be shortened. PR interval will be shortened. Okay, not the heart rate will be more. Heart rate, since cardiac cycle length is shortened, so that means rate is more. So with that you can identify that during what happens during inspiration, whether it is increased or not. Yes, it is increased. And during exhalation, expiration, what is happening? Again, heart rate is reduced. So this sort of fluctuation with your breathing, it may be noticed in healthy individuals. May be noticed, may not. So if it is noticed, then we call it arrhythmia. What type of arrhythmia? Sinus arrhythmia. Because there is P wave and followed by QRS wave. So it is a sinus arrhythmia. And it is because of respiration. So this is called respiratory sinus arrhythmia. Okay. So arrhythmia, sometimes SA node is giving impulse, sometimes not. Again he started giving. So there will be irregularity in heartbeat. These are arrhythmia. The arrhythmia means there is no rhythm. And also we can diagnose one thing. You will experience this, or some patients will say, I feel sometimes I feel my heartbeat is missing. There is dropping of heartbeat. One heartbeat is missing. He can experience this. The patient can experience it. So this is because this impulse is not generated in SA node, also not in AB node. It is generated for a moment in some other place of the heart. It may be atrial, it may be ventricular. So this sort of sudden beat which can be recorded in ECG, these are called ectopic beat. Ectopic means different, from different area other than SA node, AB node, bundle of fields. So when the impulse is from any other area other than this, we call it ectopic. It may be atrial ectopic beat, it may be ventricular ectopic beat, also called extrasystole. Extrasystole. Okay, so these things can be identified. ECG does not provide information about mechanical activity. Means whether my valve is properly closing or not, whether there is any murmur, or there is any sclerotic valve. So that sort of information it cannot. Is it working? Yes. May not. Okay. So this is the purpose, significance of this. So now we can understand this is very important for us. Other day, did I show you the ECG paper? Different waves. These waves are what? Electrical activity, potential change. These activity are potential change. Means volt that you recorded in a galvanometer. So in galvanometer, the deflection is due to voltage change. So this voltage change, you have to recall what is the voltage of this P wave, what is the voltage of this QRS wave, what is the voltage of T wave. So you have to measure it, and how much time it took for P wave, generation of P wave, how much time it took for generation of QRS wave, how much time it took for one beat. So you have to measure it, no? So that's why you have to first study this paper. From this paper we will be knowing what is the amplitude of the waves, what millivolt, what is the amplitude in terms of millivolt of each wave, and what is the time duration. Now I have a question for you. you can see one small divisions in the paper, isn't it? So when you will be going horizontally, suppose from here to here you came. So during this time, the paper traveled this distance in certain period of time. It took some time to travel from here to here. Then we can determine how much time it actually took. First, what we have to know, what is the speed of movement of the paper in the machine? It is written there, 25 millimeter per second. 25 millimeter per second. Oh, I thought you already, from other sources you know. 25 millimeter per second. Now 1 millimeter means how much time? 25 millimeter means 1 second. And 1 millimeter means how much? 1 by 25. How much it comes? 0.04. Good. Done. Well done. 0.04 second. If your P wave duration is having 3 millimeter, the P wave took 3 millimeter. That means how much time it took? 0.04 into 3? How much it is? 0.12, but it is more. It should be maximum 0.1. Okay. So in this way, we can determine in ECG, P wave will calculate different durations, different intervals, durations, intervals, and segments. Right. Duration, intervals, and segments. All the time. What are durations? What are durations? The waves. P wave. How much time from the beginning to the end of the P wave? P wave started to rise and again came down. So what is the time it took? This is the duration of P wave. Similarly, you can determine duration of QRS wave. You can determine T wave. How much time it took. So how many durations you will be having? You have to calculate 3. P duration. What are these 3 durations? P duration, QRS duration, and T durations. Okay, these 3 durations we will get. See look at the bottom of this. This is P duration. This, not this. P duration. QRS duration. T duration. Okay? From the beginning of T to the end of T. So T duration. From the beginning of Q to the end of S. So this is QRS is a complex. Okay? So you can determine different durations and different intervals. What are intervals? Intervals are, one duration will be there. Obviously one duration must be there. One or more duration must be there. Plus some time, additional time. Okay, or segment. So these are the intervals. These are intervals. For example, PR intervals. What is PR interval? Beginning from the beginning of P wave to the beginning of Q wave. Isn't it? So this is called PR interval. Important. When we will be diagnosing heart block. Means this AV block. Then QT. Another interval is there, QT. What is the QT? From the beginning of the Q wave to the end of T wave. What is the significance of this QT interval? Can you tell? Okay, remember, this P wave represents, it is represented by the auricles. Sorry, atrium. By the atrium. Okay? Represented by the atrium. Okay, and atrial depolarization. Atrial depolarization. And you cannot identify here where is atrial depolarization. You cannot find it. Why you cannot find it? Because it is merged with QRS wave. It is merged with QRS wave. That's why you cannot determine how much time it took for repolarization. Okay, so this is P wave and this is PR segment, this is QRS. And this is the isoelectric line. Connect this and this and this, you will get a line. This is called isoelectric line, means zero voltage. So P is above the isolated, so it will be positive wave. So what is the amplitude of this wave? From this you can determine. How you can determine? See in this machine, come on, anyone come, anyone. What is written there?
Gain.
Gain. And what is this?
5, 10, 20.
5, 10, 20. Come, go. So in machine you will find it is written the gain. And there are three options. 5, 10, 20. What is this? In the machine, you give a stimulus that will be having either 5 millivolt or 10 millivolt or 20 millivolt. So normally only 10 millivolt is chosen. Normally 10 millivolt. It means if you give a stimulus on this, there will be a deflection. This is not ECG. This means if it is this much, that means it is 1 millivolt. What is this? 10 millimeter. By choosing 10 means it will, if you give 1 millimeter stimulus, there will be displacement by 10 millimeter. That is equivalent to 10. That means one small division, how many millivolt? 1 millivolt means 10 millimeter. 1 millivolt, by giving 1 millivolt shock, I am getting displacement of 10 millimeter. That means 1 millimeter means 0.1 millivolt. Now you can measure how many millimeter is this? So this is the amplitude in, what is the unit? Not millimeter, millivolt. 5 millimeter, 0.5 millivolt. 10 millimeter, 1 millivolt. 10 millimeter, 1 millivolt. 15 millimeter, 1.5 millivolt. Simple? Okay. Is that clear to you now? 1 millimeter vertical displacement means 0.1 millivolt and 1 millimeter horizontal displacement means 0.04 second. Okay. Let's calculate what is the heart rate here. Can you calculate, anybody? It is determined from RR interval. RR interval from peak of one R wave to peak of another R wave. So here is the RR interval. How many millimeters are there? 5, 10, 15, 20. 20 millimeter means how many second? into 0.04. Huh? Point? 0.8. How much? Okay, so this is the time it took for one beat. This time, one beat. In 60 minutes, how many beats? Can you do it? Or you do it just like this. Divide 1500 by number of millimeter. How many millimeters are there? How many millimeter I said? There, 1, 2, 3, 4, 20 millimeter. So divide 1500 by 20. Huh?
75.
Say, heart rate is 75 beats per minute. Isn't it simple? How we have to calculate it? How many millimeters are there in between two peaks? How many millimeter, not time? This millimeter. So now you divide 1500 millimeter by this millimeter and you will get the heart rate. Now you tell me, hello, what is the value of PR segment? Starting from P, end of, beginning of Q. I am telling PR, not PQ. But you will be measuring if Q is available. If Q is available, you will be measuring the time up to Q. At the beginning of Q, not R. When Q is absent, then beginning of R. Understood? Is that clear? Okay. So in that way, you can determine the amplitude and duration of various waves. In our previous class, we have discussed about different lead systems. Have you been there? You had been there? No. In our previous class, what I discussed?
I was absent.
You were absent. You?
I was.
You are also absent. You also absent. You also absent. So what we discussed?
Just like our items.
What is ECG? Recording of electrical activity of the heart. First, I discussed electrical activity, SA node, generated cardiac impulse, electrical activity, it is spreaded over the heart. Okay? Over the heart. Then, how you are recording the electrical activity of the heart from outside? From my body surface area? You need to study the heart. You have to open the heart, then when heart will be exposed, then you can study directly. But it is not done. You are collecting information from the skin. My question is how this electrical activity of the heart came to your scale. First, go through this. This is the intraventricular septum, ventricular wall. This is a septum. From SA node, impulse came to AV node. From AV node, it is entered into the septum first. Okay? Now, when it is coming, impulse is coming, it is by forming depolarization waves. So by creating depolarization waves, it is coming to here. As a result, what will be there? This part will be depolarized. It is this impulse yet to transfer there. But now it is only depolarized up to this part. This is for this instant, it is this condition. Okay, for this instant. Okay, it is this condition. Now you can see some part of the heart is negatively charged and some part of the heart is in polarized state, means positively charged, and some part is depolarized and as a result surface is negatively charged. Now there will be definitely voltage difference, isn't it? Like battery. One end is positive, another is negative. If I connect it with an wire in the galvanometer, I will get a reflection. So since here it has developed, it has created a pole, bipole. Two polarity is there. One is positive, one end is positive charge, another is charge. So since it is there, there will be flow of current. Wave will be there out around the heart. Now you think one thing. I said it is now heart is a dipole. Heart is now a dipole having two polarity, and it is immersed in a volume conductor. The heart is immersed in a volume conductor. What is volume conductor? Volume. This is the volume. My body is the volume, and it is having different conducting thing like body fluids, like tissues. They are good conductor of electricity. What will happen if we touch it? Shock. Why? Good conductor. So since our body is a good conductor of electricity, this wave will be spreaded throughout my body surface area. And is this the permanent condition? No. It is changing. Now it is negative. Gradually this part will be negative, and this part will start to become positive. So every time there will be change. That's why in the ECG wave, every time it is changing, it is not fixed. Since here the depolation area is changing, so therefore the wave is also going to change, and it is recycled, repeated in every bit. So PQRST wave will be getting it in all the bit. It will be appearing cyclically in all bits. Okay. So now see one thing. This is the positive pole, this is the negative pole. I connected this galvanometer, positive pole here in the left hand, and this pole here. Now what will happen? The deflection is the positive side. Now tell me what will happen. I change this. The deflection will be just opposite side. That is flow of current. If it is from this side to this side, then one kind of wave I will get, or from this side to this side, again it will be opposite. That's why some wave becomes positive, some wave. One thing is you always remember, when flow of current is towards the positive pole, suppose you have placed one electrode here, and it is the positive pole. So current is moving from this side to this side, then it will give a positive wave. If it is this way, opposite to the positive pole, it will be producing negative deflection. Always you remember this. Towards the positive pole, positive wave. Towards the negative pole, opposite pole, it will be negative wave. We use different leaf system to record ECG. Two types. Remember this. Every day I cannot discuss it. Two types. One is unipolar, another is bipolar. Right. Unipolar, bipolar. Unipolar, bipolar. Okay. The bipolar. Now bipolar leads are of three types. Bipolar leads are three types. Lead 1, lead 2, lead 3. Right? Lead 1, niche, lead 1, lead 2, lead 3. And these bipolar leads are also called standard limb leads. Another name is standard limb leads. obviously these leads will be used involving our limbs. Okay, so bipolar leads, these are of three types: lead 1, lead 2, lead 3. What are these leads? These leads are nothing but electrical wire, electrodes. One is positively charged, another is negatively charged. Okay, so for lead 1, I have two electrodes. I have two electrodes. Suppose this is one electrode and this is one electrode. This is one electrode and this is another electrode. Okay, I placed it. Here is the positive, left hand positive pole, right hand negative pole. Remember this. Remember this, otherwise you cannot determine the electrical axis. Okay, so where is the positive pole? I kept it in the left hand. Now it is, let's see, what is the ECG wave? Now the ECG wave I recorded is lead 1. Again lead 2. I will connect my right hand with left foot. Left hand, right hand, left foot. It is for lead 2 connection. Positive pole in the left foot. Positive electrode will be on the left foot. Okay, so this is lead 2. And for lead 3, left leg, left hand. And positive pole will be there, negative pole will be here. So one thing we can see, this is always negative and this is always positive, and this is one time positive, one time negative. That's, you must remember always. Okay, so this is standard limb leads. Now unipolar limb leads. What are these? Listen carefully. What are these? Here also we need two electrodes. Two electrodes. So what I did, from lead 1, I am having one positive pole. Okay, you keep the positive pole. And negative pole, you keep it. Okay. And for lead 2, from lead 2, lead 1 gone. Lead 2, oh, where is the negative pole? Here. You keep. You be here. And for lead 3, positive pole be here. And the negative pole here. So for all these leads, 1, 2, 3, negative pole are combined. Negative pole are combined, and now their voltage is 0. So now this positive pole I will place in right hand, in left hand, in left leg. Okay. Now they are called unipolar. Now they are called unipolar. And when we record the ECG, their amplitude is very less. So I have made one arrangement to amplify this, augment this. What is the meaning of augmentation? So this will be augmented, amplified. That's why it is called AVR. If I place the positive electrode in the right hand, then it will be AVR. If I place the positive pole here, it will be AVL. If I place the positive pole here, it will be AVF. And the negative poles are combined together, and it is 0. So against 0, I am comparing the voltage in right hand, and left leg. So these are augmented limb leads. Is that clear to you? Okay. So how many leads do we have got? Till now 6. 3 standard and 3 augmented. Standards are bipolar, and this one is unipolar but augmented. Another unipolar limb leads are there. These are precordial leads. Precordial or chest leads. Precordial or chest leads. Precordial or chest leads. Now where to place? Here also, all the negative poles are together, and all positive and the positive terminal or electrode. It is called exploring electrode. It will explore my heart from different position. Okay, so now this exploring electrode, I will place the place where I place the electrode in case of B1. These are designated as B1, B2, B3, B4, B5, B6. Where will be the location of B1? Right sternal border, fourth intercostal space. Right side, right sternal border, fourth intercostal. See. Fourth intercostal space. This is the border, right sternal border. And B2 will be just opposite to this. And B4, forget it. B4, this is the clavicle, mid-clavicular line. This is the midpoint. From here, you imagine a vertical line. It will cross the fifth intercostal space. Not fourth, fifth. And this is the position of 4, B4. Now you do one thing. You connect B2 and B4, and at the center you place V3. If it is V2 and if it is V4, so this is the place of B3. Okay, done? 1, 2, 3, 4 gone. Now B5 and B6. Where you have to place it? This is axilla. It has 3 imaginary lines. One is anterior axillary line, another is posterior axillary line, mid axillary line. So my point of interest is anterior axillary line and mid axillary line. So both this line will cross the fifth intercostal space somewhere. It will cross the fifth intercostal space, that will be V5, and this mid axillary line will cross the fifth intercostal space somewhere. So this will be place for V6. Okay? So these are the 12 leads we usually use for electrocardiography. 12 lead electrocardiogram. Okay? So today up to this.